This is a case of a 45-year-old male who presented to the OPD with complaints of diminished vision with severe glare while driving in the night since 2 months. On examination, he was diagnosed with posterior polar cataract with a pre-existing posterior capsular rent. In a paper by Dr. Pujari and Dr. Sharma, they evaluate the role of anterior segment OCT in posterior polar cataract. There were 2 types in the posterior capsular breach cases, which were the moth-eaten appearance and the conical shaped. The ASOCT of our case showed a moth-eaten appearance. The ideal capsular axis in this case would be a 4.5 to 5 mm round and regular axis. In any type of PPC cases, hydrodissection is to be avoided. Hydrodelineation is ideal and multiple delineations help with easy removal of the nucleus. Always make sure to use low flow phacoemulsification parameters in cases like this. With low vacuum and aspiration flow rate, the central core of the nucleus is lifted up and aspirated in toto. This significantly reduces the chances of a nucleus drop into vitreous. And then the epinuclear plate is slowly aspirated. Always inject viscoelastic device into the eye, preferably a cohesive visco before removing the phaco probe from the eye to avoid sudden fluctuations. Make sure to keep the anterior vitrectomy ready in all PPC cases. The cortical aspiration is better done with the IA cut mode as the cortical matter extraction is more controlled, and in case of vitreous prolapse, the mode can be directly changed to cut IA mode and anterior vitrectomy can be carried out promptly. Another point to be noted regarding cortical matter aspiration in a case of posterior polar cataract is to disengage the epinucleus from all sides before carrying out the aspiration. In this case, due to low phacoemulsification parameters and stable anterior chamber without any fluctuations throughout the surgery, there is no evidence of vitreous prolapse. An acrylic foldable intraocular lens was implanted in the bag with the orientation of the haptics perpendicular to the plane of the posterior capsular opening. Thus, even in a complicated posterior polar cataract with a pre-existing breach in the posterior capsule, phacoemulsification can be carried out with the help of low phaco parameters, maintaining the chamber stability with no sudden fluctuations, which ensure that the PCR does not extend more than its original size, and hence the intracapsular implantation of a foldable IOL without fear.